Icing your shoulder, Jacob?
Yeah.
Testing, testing, testing. Yep. Hey, beautiful. How you doing?
I'm all right. How are you?
How's the finger?
So far, so good. Might change in a few hours here, but
Oh, just don't give me the finger, okay?
all right. Well, it is that finger too.
Well, make sure and pray for you this morning.
Thank you. I appreciate it.
How do you do with anesthesia?
Never had it before, so we'll find out.
Oh, you'll probably be fine.
Yeah, my sister gets really nauseous, I know, so that's
Well,
the only thing I would be concerned about.
I'm guessing you'll have propofol, but that'd be best guess.
Yeah.
Forty years old. I'm mad at is the screen changing? Slides
It
moving?
is not.
Slides are not moving. Okay. Okay, the slides move now?
Yes, they are.
Okay.
That is disgusting. You don't like that smell? Ew.
Okay, try it again. All right, they change now?
Yep.
Okay.
No. Okay, you're great. Next. No, seriously. So, is this like for my friend today? Yeah. This one smells good. This is the kind of candle I like. You don't like this smell, this one? I like this one way better. Just what? You sure says the volleyball team delivered up today?
I don't know if it's better. That's more fruity.
Right. I like that one better.
And this is how you start cooking.
Really not. I like that one better. Does it make up smell? I don't like the fruit. What smells better? That smells different.
Wait, I guess.
They're both mine, but that's fine. You got just have to speak.
That one's the most fruit though.
I would burn both.
My favorite is and you like Brian.
Yeah.
Oh,
Dang.
yeah.
Now let's
And with a wood.
Dr. Red, now let's see what this just started as a fun from Grandma's kitchen.
That's,
Doesn't it smell so good? No, it smells like.
oh, that is good. Yeah.
He's the only one who's so against it. This one smells beautiful. Just stick it really in your nose.
Oh, it is. That's a little more subtle. That's a more subtle.
Isn't this weird?
It's a, yeah.
What one is better?
I like them both. I think I'd like that one better in a living room. I like that one better in a bedroom. Okay, everyone, calm down. Okay, hello, we're starting. Corinne,
Why did you gotta pick on me?
because you're pickable. Okay, cállate.
Grabbing me up the wall.
Okay, Dave, now you heard this one? Mucha droga. Yep, shut up. Literally, shut up, dear one. Okay, quiz Friday.
Okay, he's talking about the quiz.
Quiz Friday will be over 14. In the back of the chapter, I think you mean.
Yeah.
Questions at the end of the chapter, those.
Some trippy ones.
If the spirit moves, sure.
Pray that he doesn't.
Very good. So, did everyone get the practice midterm I sent out?
Yes.
Okay, that is material over which you'll be tested. Use that to guide your studying. The test will be the same format, multiple choice, false, so on and so forth. Okay? Test is Monday. Okay? If you need some sort of special dispensation, something like that, you want to take it at the Academic Student Connection Center, let me know. Amber Holloway has a copy, well, she will have a copy of the exam. Mrs. Schaefer will send her one. Go see her, make an appointment. Do tell me so I know not to expect you on Monday. That way I don't freak out. Where's Jacob? Where's Aaron? Where's whatever? If something happens, make test positive, whatever, you have to then go into the deep dark dungeon of, quarantine. Let me know. Yeah, my daughter's on her second quarantine now at Greenville. Oh boy. I was chatting with her on my phone and she said, Dad, I've taken time. I've kind of figured this out now. Kind of know how to do this. Getting good at being quarantined. I'm not sure I want a skill like that. Anyway, so if something happens, just keep me in the loop. Let me know. Last thing, don't forget seminar this Friday, White Auditorium. You need to make some sort of, you need to say you're going to be there so that we know how many people are going to be there. There will be a Zoom link. You watch online, live or recorded or whatever. If you have questions, submit them beforehand. We can't pass the microphone around. Again, the topic is 19, masks, flasks, and tasks. So masks, why are masks useful? Flasks, some experiments to demonstrate some health comment, public health procedures, tasks, things that you should do, not just to stay safe, but to keep other people safe as well. You go see Mrs. Schaefer. The announcement didn't say anything about that. Sign up link on the announcement. Okay, if you're not sure about it, reference the email you were sent by Kathleen, Mrs. Schaefer. Otherwise, go see Mrs. Schaefer and she'll just sign you up. All right. How's that shoulder there? Good? Feeling better? Okay, it's just a pain or it's a... So you're still rehabbing? So it gets stiff? Okay, but it's fine. Yeah, it's just, okay. Injuries do that, they get stiff. You just have to learn how to manage them. It's part of being an athlete, injured all the time. Way it goes. All right, cardiac output, then we hope to get to the lungs. Meredith has her surgery on her finger. So let's pray for Meredith. It goes under the gas and under the knife as well. Lord, thank you for a little colder day today, or a lot of colder day. And we pray for Meredith as she has her procedure for her finger. Thank you, as a good orthopedic surgeon who can work on her hand, I'm sure as a golfer, being able to grip a putter and a driver and an iron are all quite important. Help her to respond positively to anesthesia, help get sick, and we pray that she heals quickly, that surgery is a success. Also, we pray for Jake's shoulder, help him to loosen up and feel better so he can be throwing people out at third base. And thank you for our athletes that they represent us so well. We pray now for them and for everyone else for Monday that you should help them prepare properly for this exam. In Jesus' name, amen. All right, so blood flow, very simply, is going to be the distance that the blood covers in a certain period of time. The distance the blood covers during a certain period of time. So there are several things that are going to influence blood flow. Pressure, of course, is going to influence rate of blood flow. The diameter also of the blood vessel, the area of the blood vessel, is going to be a determinant also of that rate of flow. So your book has this equation on page 464. It shows you that the change in pressure multiplied by the radius of the blood vessel to the fourth power times pi. Pi, of course, is a constant. We all know that apple pie is the best. That's a constant. And 3.141, blah, 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 so on and so forth, divided by the length times eta times 8. And eta is this factor that has to do with resistance. So resistance, eta also has to do with viscosity of the blood as well. So consider this. If you're dehydrated, is your viscosity of your blood going to be higher or lower? It's going to be higher. So viscosity is into resistance, essentially. Resistance also has to do with not just internal rubbing of molecules, but also the rubbing against the walls. So the wider the walls, that means that you have more blood to flow through. The more constricted it is, the less volume. Also, you're going to have more blood interacting with the walls for speed as well. That's going to increase resistance as well. So you look essentially, oh, and pressure-wise, it should be pretty clear, I think, that pressure on the arterial side will be high relative to pressure on the venous side. Pressure on the venous side is very, very low relative to pressure on the arterial side. Now, when you get into the peripheral circulation, your resistance is going to be determined largely by the diameter of the vessel. And the book, essentially, this is figure 1415. And as you can see, essentially, resistance is going to be the length times the viscosity of the blood divided by radius to the fourth power. So as the radius goes up, your resistance goes down, and it goes down substantially. As the radius goes down, it's going to start to raise the resistance pretty substantially as well. So this picture here shows essentially because it's raised to the fourth power, you can see that your blood flow really takes a hit as your vessel diameter goes down. That means your flow in smaller vessels will be lower. It also means when you vasoconstrict, you can raise the resistance pretty substantially. So the upshot about all this is that your arterioles are your smaller arteries. Since your smaller vessels have the most resistance, and since arterioles per vessel have probably the most muscle, when they're narrowed by vasoconstriction, and because they're under the greatest pressure, they represent the greatest potential resistance blood flow. So your arterioles are the vessels that ultimately control blood vessel in many ways. Now your book on page 467 has some of the molecules that can control not just vessels, but the arterioles in particular. When you think of these vessels here, you should think arterioles, because they're going to have the greatest effect, the greatest influence on blood pressure. So let's take a look at the ones that cause constriction. First of all, your alpha adrenergic receptors, alpha 1s in particular, they'll cause vasoconstriction. So that is going to be due to sympathetic nerve activity. This is one of the reasons why anxiousness, why stress, so on and so forth, can cause your blood pressure to rise. If some of you get very nervous when you go to the doctor, the nurse takes you back, or the MA, they take your blood pressure, they look at you and they say, my, it's high today, so-called white coat syndrome. That is a fear of healthcare words essentially telling you something you don't want to hear, and your blood pressure is high. That's the reason why sometimes they are obligated to take your blood pressure, but they often ignore it because you're nervous. And if you're watching your blood pressure on a regular basis, a high blood pressure at a doctor's office may really not mean anything, or it might. You really need to get blood pressure over a consistent period of time, and there's a device that the doctor can give you called a Holter monitor. And a Holter monitor, it fits around your waist, it has a cuff, and it takes your blood pressure throughout the day. And then it has a recording, and you look at that recording, that tells you essentially what your blood pressure is throughout the day. That's if there's a worry that you have hypertension, that's really the way to detect it. Others include angiotensin 2, that is made from angiotensin 1, which is made from angiotensinogen. Angiotensinogen is by the liver, is converted to angiotensin 1 by an enzyme called renin. That's made by the kidney. And the kidney will make this if it thinks that the perfusion of the kidney is low. This is to increase perfusion to the kidney. So angiotensin 2 is made from angiotensin 1 as it circulates through the capillary beds, particularly of the lungs. They will have an enzyme called angiotensin converting enzyme that converts angiotensin 2 to angiotensin 1. That's a very powerful vasoconstrictor. And this will also raise pressure. Consequently, that enzyme is a target for many antihypertensives. Others include ADH. Now, ADH only causes vasoconstriction at rather high concentrations. So unless you're severely dehydrated, that's usually not going to be much of a player. However, in hospitals, if someone has shock, during shock, you get massive vasodilation, blood pressure crashes, you don't have good fusion of organs. ADH, which comes as a product, vasopressin, that can be given intravenously to get your blood pressure up so you can perfuse those tissues. Others that will cause vasodilation, histamine, usually will cause vasodilation in capillaries. Usually doesn't cause any sort of systemic vasodilation. Bradykinins, these are more systemic. These are rather powerful vasodilators. Your parasympathetic nerves, of course, and cholinergic inputs can, in some cases at least, to arterioles and skeletal muscles. That is due to cholinergic input. And then beta-adrenergic, in particular beta-2 adrenergic input to skeletal muscles. That causes vasodilation. Prostaglandins tend to work locally. Prostaglandins have a very short half-life. If they work, they tend to work locally. They don't tend to circulate throughout your bloodstream and cause systemic effects. Now, if the blood pressure to a particular organ becomes high for any particular reason, usually you'll get constriction to prevent that organ from being damaged by excessive pressure inside the organ. That's called myogenic control mechanisms, myogenic control mechanisms. These are used as protective agents, usually to protect organs from getting the delicate vascula from exploding inside. Metabolic control mechanisms are in response to certain metabolites. The big one here is pH. Remember, we talked about the capillaries in the lungs vasodilate in response to acid. That's an example of metabolic control mechanism. So CO2, pH, adenosine, potassium, all of these can promote vasodilation under certain conditions. And the belief you'll see online, people will say, oh, if you have high blood pressure, eat a banana, because bananas are full of potassium. No clinical evidence for that, as far as I could see, but potassium, usually the result of damaged tissue releases potassium. The vasodilation is to rid the tissue of debris that can clog the vessels. That's what that is. So, no clinical evidence that eating bananas lowers your blood pressure. Hyperemia is a constriction, a vasodilation that is caused after the organ has undergone vasoconstriction. Or it can be a gorging of blood that's due to increased demand. So we talked again about adaptation to exercise. We saw hyperemia in the lungs. That's a so-called active hyperemia. That's an adaptation to exercise. So hyperemia in skeletal muscle. You might notice if you do a lot of weight, if you look in the mirror, you might notice your cubital vein is actually bigger than it normally is. Some of you are looking at me as if to say, no, it doesn't. Well, actually, it does. It does. Next time you're in the gym, try lifting very heavy weights that get you really tired. Then look at yourself in the mirror. I'll bet you'll notice your cubital vein is more noticeable in the mirror in both arms. Also in your legs, you might notice your surface veins, they'll actually engorge with blood. That is active hyperemia. You don't believe me? Try it. Try it. You'll see it. The muscle demands more, so you get vasodilation, gets engorged with blood. That's in response to increased demand. Active hyperemia. Reactive hyperemia occurs after a tissue has undergone vasoconstriction. Then, if that's relieved, the tissue, because it's been starved of tissue and because it's built up end products, CO2, lactate, things like that, it'll vasodilate in order to wash out those metabolic products and to gorge itself on oxygen that has been lacking. A good example of this is, let's say at your computer. I'm sure this has happened to you. You sit on your leg, this, and type, and then after, 45 minutes, you can't feel your foot anymore. So you get up, try to work on it, and you're not sure you can do that, and then you get that pins and needles feeling. Then it starts to tickle as if the blood starts to flow in it, and you have to kind of like that, and maybe even something like that. That's due to the vessels in your foot getting engorged with blood. The rushes in, that's what that tickle is. Then you actually have to walk a little bit, pump those veins to get the excess blood back up. That's an example of reactive hyperemia. Or, Ed, if you've been lying on your arm and then you wake up and your arm's in swings because it's dead, and then you have to, it doesn't quite work at first, it tickles. Because especially if you stand up, because gravity now pulls the blood. Reactive hyperemia. Sorry? Yeah, that's in the nerve. The nerve now is built up ions, and now that's been relieved. The nerve now has to pump out all the ions that built up. that's a nerve issue. That's the pain part. It was potassium, actually. It's potassium. Pass that around and have drinks. Mhm. Yeah, you're also trying to stimulate your sympathetic nervous system so that heart rate's higher, and that way the dilation. Muscles is already primed. You're priming yourself essentially. So you get up, you run in place for 45 seconds, minute and a half, depending how big a stud you are. To me, it's 15 seconds. If it's you, probably 90 seconds, just to get you going. This time, the baseball guy on the field, notice how they warm up. They'll take the ball, they'll do this. They'll do this. Pitchers, actually, some pitchers will take a weight and we'll just do this. Openers usually do that. They have to warm more slowly. They'll just take a weight and do that. And that's, again, trying to wake those muscles, get it engorged with blood so they can now throw. This is a phenomenon that's actually more common than you think. So blood pressure is actually regulated on a minute-by-minute basis in your body. And the control of blood pressure minute by minute is due to these receptors. They're special nerve cells, they're stretch receptors that are found in various large blood vessels. So these are the baro receptors. Baro means pressure. So these detect pressure, but they detect it in the form of stretch in the walls of the vessel. See? So these are in the aortic arch, the wall, of the aortic arch, and also in the wall of the carotid sinus, which is basically a little bulge where the internal carotid artery just above is slit from the common carotid in the neck. There's an old EMTs used to be taught to massage the carotid sinus to decrease tachycardia. That's not taught anymore. Any of you EMTs? No, that's not taught anymore. EMTs, because you're in a panic, they tend to do it too vigorously and it damages carotid sinus, so they stopped teaching that. So these stretch receptors in the aortic arch, the stretch receptors will join up to form the vagus nerve, the so-called 10th cranial nerve. And in the carotid sinus, they're going to form the glossopharyngeal, or the 9th cranial nerve. These are sensory branches of those nerves, by the way. They travel to the brainstem. They synapse at the nucleus tractus solitarius, which is in the medulla oblongata, and that will relay the information to the cardiovascular centers, which are in the lower third of the pons. So these two are right on top of each other in the brainstem. So the cardiac control centers have two main centers. They have a so-called cardiac accelerator and cardiac decelerator center. Cardiac accelerator and cardiac decelerator center. Let me try to draw this for you. Again, I'm going to apologize ahead of time for artwork because you know my artwork sucks. And Meredith wants some of you to take pictures for her because she won't be able to see it. So, who took my chalk? All right, so this, okay, it's ugly, but you get the point. That is the pons, essentially. And this is going to be dorsal, this is going to be ventral. So the NTS is going to be right about here, paired. That's the nucleus tractus solitarius. And you'll then have a series of nuclei here. You then have another nucleus actually that's down here. And these two centers, they are the elements of the card decelerator center. And then the elements of the accelerator center are actually going to be located within the NTS, like that. All right. So you receive from the aortic arch and the carotid sinus. So let me get some white chalk over here. So these are going to connect here, and this will connect with that, just that. All right, and then these NTS, let's do sympathetic in purple. The sympathetic output then is going to come from here, and it's going to be joined by this here, and that's going to go to that's sympathetic. Let's go sympathetic, and then also this is going to go to various peripheral vessels. So to do a vessel, we'll do a nice vessel here like this. Like that. So that will cause vasoconstriction. This will cause ink heart rate. All right, with me so far? And for parasympathetic, let's do parasympathetic since it's already in green. Let's do that in green. So these are going to go just to the heart. And remember, those will slow the heart down, but don't affect vessel diameter. Also, don't affect contractility of the heart. They just affect heart rate. Parasympathetic system has a chronotropic effect on the heart. Does not have an ionotropic effect on the heart. Only the sympathetic system has an ionotropic effect on the heart. Aaron, you're looking at me funny. Ionotropic, you know what that means? Remember what ionotropic means? Means it increases contractility. Increase contractility.
How are we looking at it? Is it like for the top?
It's you took the pons and you cut it in half.
Right.
So that is a cross section of the pons. And so this whole mesh here is a cardiac control center. That lower third of the pons. So if you're, oh, this is gonna look really ugly. Cerebellum. See, then the pons kind of comes out like this. And then, so the lower third, it's going to be right about, right through there. Good night, that's ugly. You get the, room? How about a castle? All right, so that's the plumbing of the baroreceptor response. So the cardiac accelerator center speeds up the heart rate, increases cardiac contractility. The decelerator center slows down the heart through the parasympathetic nervous system. Both affect the rate, but only the sympathetic system will affect the diameter of the vessels and the contractility of the heart muscle. As blood pulses through the carotid sinus and the aortic arch, the walls get stretched out. In response, the baroreceptors will fire more frequently. So you get more impulse going to the cardiovascular center. Higher the pressure, the higher the frequency of the nerve impulses. So let's say you're running to catch the bus. Your blood pressure now will rise. The increased pressure stretches the walls of the aortic arch and the carotid sinus. The baroreceptors now start to fire at an increased frequency. The glossopharyngeal and vagus nerve carry increased signal to the cardiovascular centers of the brainstem. What do they need to do? They need to bring the pressure back down. So they will inhibit the sympathetic nervous system and stimulate the parasympathetic nervous system. Specifically, the vasomotor center decreases the vasoconstrictive effect of the sympathetic system. The arterioles dilate. This decreases total peripheral vascular resistance. There's a decreased constriction of veins that allows the blood to pool in the periphery rather than returning to the heart. Decreased venous return means decreased cardiac load. Since you have decreased diastolic filling, that decreases cardiac output. The cardiac accelerator is inhibited. That reduces sympathetic effects on the heart. That lets the heart work slower and less forcefully, thus reducing cardiac rate and contractility. While the decelerator is activated. Now, let's do the flip side. Let's say in a terrible traumatic accident, you start losing a lot of blood. Your blood pressure now starts to fall. The decreased pressure on the walls of the aortic arch and the carotid sinus causes it to become less stretched. Now these baroreceptors fire less. Because they fire less, you have decreased signal going to the cardiovascular centers of the brainstem. Now they need to bring the pressure back up to normal. So these centers will stimulate the sympathetic nervous system and inhibit the parasympathetic nervous system. Specifically, the vasomotor center increases the vasoconstrictive effect of the sympathetic nervous system. The arterioles narrow, peripheral vascular resistance goes up. There's increased constriction of veins. That means you return more blood to the heart rather than allowing it to pool in the periphery. That means you have more preload. That increases cardiac output. While the accelerator is stimulated, decelerator is inhibited. So your parasympathetic input to the heart is inhibited. Parasympathetic input to the heart is stimulated. These changes, therefore, can save your life, as you see here. We can illustrate this really simply with a very simple experiment. So push back from your deck like you're going to stand up and just relax. Now, take your fingers, either get a pulse, a radial pulse, or a jugular pulse, either one. Look at the clock. You need to uncross your legs there, Jack, because you're going to stand up pretty soon. Look at the clock, get a pulse. Okay, got a pulse. Now stand up. Now, take a pulse. Pulse go up or down? Went up. Why? Because gravity pulled the blood away from your brain. You need to raise cardiac output to get the blood up to your brain. As you sit down, now blood will start to pool in your peripheral system. Now the cardiac rate will go down. This is a moment-by-moment adjustment of blood pressure. That's the baroreceptor system. And we went through all that, blah, 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 so on and so forth. Your book has this nice picture showing you essentially how this works. And then the smart art essentially shows you the players, vessels, heart, carotid, sinus aortic arch, glossopharyngeal vagus nerve to the NTS, and then to the cardiovascular system, the vagus parasympathetic output, and then the sympathetic nerves in the focal ganglion down here to the vessels and to the heart. And that doesn't work and what have you. Also, you have another set of baroreceptors called cardiopulmonary baroreceptors. Cardiopulmonary baroreceptors. These are embedded in the walls of the right atrium and right ventricle, and in the pulmonary artery and the veins. The walls of the right atrium, right ventricle, pulmonary artery, and veins. These are relatively low pressure areas. So the stretch of these walls depend on blood volume. Blood volume. It depends on the fullness, essentially, of these cavities or vessels. So as the blood volume increases, these baroreceptors will fire more frequently through the vagus nerve towards the cardiovascular centers of the brainstem. These centers then send signals toward the heart, increasing the heart rate and increase cardiac output. That increased cardiac output means more blood to the kidneys. That means more water and sodium will get excreted. That will lower volume. This is called the Bainbridge reflex. The Bainbridge reflex. If you doubt me on this, you can do a very simple experiment where you get one of those big liter bottles and you gulp a whole liter bottle of that, and you take your pulse, your heart rate before and after. Your heart rate will be consistently higher after gulping that liter of water after you've absorbed it, because your heart is responding by this baroreceptor response. Now, when the cardiopulmonary baroreceptors sense high blood volume, they send a signal to the vagus nerve via the vagus nerve to the hypothalamus. That causes the brain to reduce the secretion of ADH by the posterior pituitary. Therefore, you have decreased water resorption by the kidney, therefore more water is lost in the urine. Cardiopulmonary baroreceptors also stimulate the muscle cells of the atria to secrete a peptide called atrial natriuretic peptide. Atrial natriuretic peptide. This causes renal arteriole dilate. It allows them to receive and filter more blood, and it inhibits water and sodium resorption. And if the blood volume decreases, the baroreceptors get less stretched. That reverses all these effects. The heart rate slows down, ADH is made, less ANP is made, and you get less water and sodium excretion. That restores blood volume, as you see here. Okay, and then aldosterone and ADH also increase blood pressure. Aldosterone, because it causes retention of sodium, increased sodium concentrations in the blood will cause the blood to draw more water from intracellular spaces, intercellular spaces. That will increase blood pressure. And then the atrial stretch receptors, those are the cardiopulmonary receptors we already talked about. Atrial stretch receptors, so on and so forth. Blood pressure is measured indirectly using a sphygmomanometer or a so-called blood pressure cuff. You use the so-called auscultatory method. And here's a picture of somebody getting their blood pressure taken. If that's me, I'm never smiling when you take my blood pressure. I get bloody nervous when you take my blood pressure. I am terrible, just terrible. So this essentially, you're using the cubital vein. And you're using pressure essentially to cinch it down. And then when it cinches down, you listen. As you reduce the pressure, you're listening for turbulence. When you start to hear turbulence, that means the pressure has burst open. That's your systolic pressure. That turbulence then will start to, you'll hear a set of beats. That's a pulsing from the heart, essentially. When that pulsing stops, that tells you the vessel's all the way open. That's your diastolic pressure when those sounds stop. And the blood pressure is very easy to take. The key to taking a good blood pressure is not letting the pressure out too fast. Time and time and time and time again. I'm in my doctor's office, and they say, "Oh, your pressure's fine." Are you sure about that? Of course, I don't know, but no, actually, I don't, because if she takes it again, it's going to be high. I get so nervous. I get so nervous when I go to the doctor's office. It's awful, just awful. I'm terrible. And the nurse just looks at me and she just shakes her head. I said, "What is it with you?" Because I have two monitors at home, and I take it every day, constantly. I keep a record of it. I send it to my doctor. It's fine, except when I go to the doctor's office. It's ridiculous. So then it's high. So there are monitors you can buy now, electronic monitors. The brand most recommended by most healthcare providers is Omron. That brand that everyone recommends. You can get cheap ones, more expensive ones. You get ones that'll wash your dishes practically. They'll link to your phone. Yeah, you don't have to enter anything. You just take it and they'll put it right in your phone. Then when you go to your doctor, you can push it up on your phone and you can show your doctor what has been throughout the day. Essentially, it's really pretty cool. So yeah. Anyway. All right. Any questions on cardiac output, anything like that. We switch systems and go to lungs. Very good. Okay, so we're going to switch here to the lungs. Okay, Meredith, are those moving for you?
Yes, they are.
They are? Good thing. Okay. All right, respiratory system. Now, the respiratory system is divided into a zone that sucks the air, and then a zone where the air actually will have the proper exchange of oxygen for CO2 with the blood. So there's a conducting zone, that's the plumbing that gets the air to the respiratory zone where the actual exchange takes place. So the terminal alveolar sacs and the respiratory bronchioles, that's the only part where the exchange takes place. Everything else, trachea, bronchial tubes, primary, secondary, branching bronchioles, terminal bronchioles, are all conducting system, all conducting zone. So you can see this here, essentially, the primary bronchus, trachea. Here you have the larynx that connects. You can feel it here, that's it right there. And this is called the carina, where the two branch, the carina is loaded with sensory nerves, and the cough response is very often due to activation of those sensory nerves in the carina. And then the branching, and then the lung itself is divided into lobes, upper, middle, lower lobe, so on and so forth, depending on these. And then here you have your terminal bronchial, then your respiratory bronchial, and the alveolar sac. Old books call this an air sac. It's now called an alveolar sac. These are the great plaque clusters, and those are lined with a filigree of very, very thin capillaries. That's where your gas exchange takes place. So yeah.
So what causes like a dry? Because I know if there's like phlegm in your throat, it'll activate the sensory nerves. But what if like there's nothing to cough up?
Well, dry coughs can be activation of sensory neurons actually in the pharynx. Those can actually cause a cough as well. If you, in fact, when you get your tonsil swabbed, you get that swab on the back of the throat, you cough. That's a cough response. So that could cause a dry cough as well, and that's usually due to postnasal drip or something like that. Some drugs or some conditions actually will cause you to hypersalivate. If that drops in the back of your throat, that will cause you to cough. Certain fluids can cause you to cough as well, particularly if they go down the wrong pipe. That simply means that they've, instead of the epiglottis closing and it's going down into the digestive tract, it's around the epiglottis and it tickles the top of the larynx, and that'll cause a pretty good cough response. You feel like you have a frog in your throat, that's what that is.
So like when you have COVID.
That's due to the inflammation produces enormous amounts of mucus and sloughing and pus and what have you, and that's if that doesn't get expectorated, it's got one to go essentially, and that's what causes all the coughing. So the alveoli have two cell types. There's a flat cell that forms a sac, and the type 1 cell is going to form it. Then the type 2 cell looks like a little foosball. You know those foosballs that you buy in the store for toys? Type 2 cells look like a foosball, and they make surfactant. So here is essentially, here's the foosball, the type 2 cell. 1 cell is flat. It forms the sac. And the capillaries, you can see, are very close by. There's not much space at all separating the capillaries from the alveoli. The type 2 cell surfactant. Surfactant's really important. If you don't have surfactant, then as these undergo constriction and expansion, water in there may cause them to collapse. You won't be able to open them then. Surfactant acts as a detergent that gets in the water, decreases the adhesion properties of water, so that now those alveoli can open. And also, there's evidence that the type 2 cell is damaged, that if the type 1 cell is damaged, type 2 cells can actually divide and become type 1 cells and actually heal the alveoli. All right, so here is a capillary. Here is a type 1 cell that you can see right here. And take a look at this, just appreciate essentially how close together the endothelial layer of the capillary is versus the type 1 alveolar cell. Man, look at that. That's really, really close. It has to be that in order for proper gas exchange to occur. And here is a capillary. Here are these alveoli. Notice the alveoli are pitted. That's so you can share gases between alveoli. The alveoli also, in the extracellular matrix that surrounds them, are very rich in elastin. The elastin allows expansion, snap back. Elastin, expansion, and snap back. When the lungs get damaged and you get fibrosing of the lungs, the elastin gets replaced with collagen. And now the lungs are no longer elastic. That's called pulmonary fibrosis. And that's due to repeated damage of the lungs, or if you get really severe pneumonia or something like that. This turns out to be a sequela of certain types of COVID-19 infections. If you get the really bad pneumonia and get ARDS, acute respiratory distress syndrome, where the alveolus fills up with an inflammatory fluid, and you get fluid actually outside. Well, and you see this on a X-ray. That's called consolidation. Consolidation. That's what is meant by consolidation. I like pictures sometimes, so. Okay, guys, you gotta admit that's cool. Just look at the really beautiful, delicate structure of the alveolus there. It's just really gorgeous, isn't it? And that's what essentially allows gassing to take place. All right, back to the ranch here. So the pharynx is the cavity that connects the buccal cavity with the laryngopharyngeal cavity. The pharynx, of course, has a little trapdoor called the epiglottis. The opening is the glottis. The epiglottis is the trapdoor. That's just made of cartilage. You then have vocal folds, otherwise known as vocal cords. They're part of the voice box, the larynx. And the larynx is the opening to the trachea. That's a sturdy tube. You have these C-shaped rings of cartilage. And this is all part of the conducting zone. There's several types of cartilage. You probably went over those in PE. I don't want to belabor that. But safe to say, this is called the thyroid cartilage because the thyroid sits right on top of that. And if you take your thumbs and put them together, essentially kind of like that, overlay that, essentially that's what your thyroid would look like on top of that. And then this branches, your vagina branches then into a left and a right primary bronchus. Notice that branching is not equal on either side. Much earlier branching on the right side than you do the side. That's why the lung is broken into 3 lobes. Left lung is broken into 2, which you learned in A&P, so not going to belabor that again. The ducting zone, if you look at it under a microscope, which you looked at, I hope, in the first lab, you probably saw a tracheal epithelium. It is humidified quite well. It's also loaded with goblet cells. Goblet cells make mucus, and then the apical surface are decorated with cilia. So the cilia move the mucus up to the throat. There it is swallowed, and the mucus works like flypaper. So anything you inhale gets stuck on the side. It's very hard for things all the way down to the lung, unless they're very, very, very fine. That's called the mucociliary escalator. Mucociliary escalator. And mucus is full of negatively charged sugars, very highly hydrated, very sticky, and like I said, it's flypaper. So I, at times, have the very mucus in my body because they seem to make too much of it sometimes, but mucus is a good thing. Without it, you get sick far more often. So you should close your eyes and be thankful for your mucus. Now, if something manages to get down to the lung, there is one white cell called an alveolar macrophage. This is the floor manager of the immune response within the lung. This is a professional phagocyte, and it gobbles up anything that gets in the lung. It also makes a variety of cytokines recruit other cells to help it out if it needs further help. It can also take things to nearby lymph nodes. There are lymph nodes nearby, the mediastinal lymph nodes and other lymph nodes from which you can recruit lots and lots of help. This is a good place to wait. I have 1 more minute. So we'll finish this. And then, well, there it's 1:20. Okay. So the diaphragm, hit the mechanics of breathing. Please review the muscles of breathing. Remember, this is physiology. I don't review anatomy. I just reference it. That's your job. So review the muscles of breathing. Review the intercostals, sternocleidomastoid, scalene, things like that. Review those. And then we'll talk a bit about the mechanics of breathing and then go on from there. All right. Okay, Meredith. Make us proud, okay?
Alrighty, will do.
Blessings, girl.